Professor Muhammad Ibrahim. My name is Nader Bayoumi, and the title of my presentation is Childhood Glaucoma, Story of a Life, or should I call it actually a story of love. Life is a gift, blessed by love. Love is the beginning and the endless end. The beginning is a birth. The birth of life is unleashed by a sparkle. So come along, close your eyes, reach out for the whisper as an adorable couple meets. So the lovers meet and love story continues and they decide to marry. Please, sir, is there anything we should do before we tie the knot? Well, there's that issue referred to as childhood glaucoma, which refers to any glaucoma below the age of 18 years if you're in Egypt, or below the 16 years if you're in Europe. Is this a common disease, sir? Well, the primary form of the disease is the most common, with highly variable population-specific incidence rates from as high as 1 in 1,000 in Romanians to 1 in 30,000 Europeans. Of course, the secondary forms of the disease have a much lower incidence rates. Is it something related to our genes we should know of? Well, here is what we know currently about the genetics of childhood glaucoma. It is a genetic disease. The inheritance pattern is Mendelian. All the inheritance patterns are reported. The most common mode of inheritance is autosomal recessive. It's not extinct. With penetrant, meaning that some individuals with pathogenic variant may not express the trait, and variable expressivity, meaning that the disease may have different severities in different individuals. The most common genes implicated that we know so far are the CYP1B1 and TEK for primary congenital glaucoma, MYOC and CYP1B1 for juvenile open-angle glaucoma, FOXC1, PITX2, PAX6, and CPAMD for glaucoma associated with non-acquired ocular anomalies. And as you can see in this Venn diagram, there is a considerable phenotypic and genotypic variation among the different types of childhood glaucoma, with CYP1B1 occupying a central location in these genotypes for childhood glaucoma. And these are other exhaustive lists of the genotypes that are involved that are known so far. So, given this, how can you help us? Here is what you should know about the genetics of childhood glaucoma. Clinical examination establishes a clinical diagnosis of an affected individual. Gene-specific therapies do not yet exist for childhood glaucoma. Molecular diagnosis, for the management of glaucoma, there are currently no clues, only guidelines. For the diagnosis of syndromes and systemic features, maybe. For testing at-risk relatives, maybe another guidelines. So to conclude, multiple genes are implicated in the causation of childhood glaucoma. All forms of Mendelian inheritance are recognized. Family pedigree and link to affected relatives assists in risk assessment, and molecular testing for implicated genes may highlight the risk of disease developments. The lovers wed, starting their happily ever after journey. And then one day, she feels another soul blooming inside her womb. Congratulations, man, you're expecting. Is there anything I should take care of to protect my child? Well, this is what we know so far about the teratogenicity. There are certain drugs that are definitely known to cause a teratogenic effect on eye development, and other drugs that may have the potential to cause teratogenic effects. So thalidomide is definitely related to ophthalmos. Coumarin anticoagulants are definitely related to Peters anomaly as well as quinine. Opioid analgesics may cause congenital glaucoma, and so can angiotensin-converting enzyme inhibitors maybe, and this is another list, exhaustive list of drugs with potential teratogenic effect on the eye. Oh, our tiny miracle is about to bless our life. I cannot wait to see my baby's lovely face and look into my baby's bright eyes. Oh, why does my baby's eye look different? So, how do you mean by different? Is it whitish gray and not brown and black? Is the size of the eye larger than usual? Well, the causes of a cloudy cornea at birth are multitude and include congenital glaucoma among other causes. And the causes of a large cornea at birth are also multitude and include congenital glaucoma among others. For a cloudy cornea, the possibility of this cloudy cornea being or representing a primary congenital glaucoma is about 25%. Whereas the prevalence of a large cornea being a congenital glaucoma eye is around 63%. And to confirm the diagnosis, there are suggestive signs in the cornea, which include edema and not just a cloudy stroma, which may signify a storage disease, a broad limbus that is not referring to a sclerocornea, which is associated with the flat cornea and the white corneal periphery, Habs stria, which are these two parallel lines. If the fundus is visible, optic nerve cupping beyond 0.1 to 0.3 or asymmetry or notching of the optic nerve are clues, as well as the elevation of the measured intraocular pressure, although this is less important in childhood glaucoma. And the most conclusive evidence is progression, that is change over time of any of these parameters. So it's a purely eye doctor problem. Our pediatrician has no role. No, ma'am, attention, please. The pediatrician has an instrumental role to manage the associated systemic conditions that may be present with the childhood glaucoma. Examples include, but are not limited to, phakomatosis, such as Sturge-Weber syndrome with its systemic features, metabolic syndromes, chromosomal disorders like Down syndrome, Rubinstein type, ectopia lentis syndromes, neurofibromatosis and congenital rubella syndrome, among others, but this is just a few examples. Oh, if it's that abominable disease. So what will we do? Well, to manage, treatment may be medical or surgical. About the medical treatment for this neonatal onset childhood glaucoma, we have to highlight that the systemic effect of medications are dangerous, reported at risk of about 4% of beta blockers and 5% of topical carbonic anhydrase inhibitors. Yet the safest remain the topical carbonic anhydrase inhibitors, the most effective being beta blockers and prostaglandins having a similar efficacy to timolol with a good safety profile. Brimonidine is absolutely contraindicated in children, absolutely contraindicated. Pilocarpine has no proven efficacy, and the relatively new modalities of the rho kinase inhibitors have a scarce evidence, and they may be more effective in lowering the episcleral venous pressure in secondary glaucomas. Temporizing measures, systemic acetazolamide may be used at a specific dose for children. So what about surgery? Well, there are odds for early surgery, that is in the first 2 months of life, which include an unsure diagnosis, a narrow palpebral fissure, an immature eye, a high failure rate with the success percentage reported for primary surgery almost 50%, and the conjunctival scarring decreasing the chances of success of future surgeries. Actually, a very landmark study by Dr. Sushmita Kaushik in India found out that surgery in the first month of life yielded an almost 46% need for redo surgery. So almost half of these children will need redo surgery if the child is operated upon in the first month of life, and only a bare less than 1/3 of these will actually have a good visual acuity. So the solution is a measurable, titrated, informed, knowledgeable delay that will yield better outcomes. Thank you very much. We'll follow your instructions. You know what? I think I was just delusional. My child's eye are just perfect. So a winter and the fall pass by, and past the 3rd month to the end of the first year, oh, my child's eye is tearing. My child's eye is getting bigger as the days pass by, and my child's eye is definitely changing. Well, what we know, ma'am, that the child's eye will grow if the intraocular pressure is elevated up to the 3rd year of life. Is the child's eye changing or tearing excessively because there may be a trauma signifying an infective keratitis? Does the child have a common cold? It may be an infective conjunctivitis, and it still may be an obstructed tear duct, ma'am. So don't worry. To confirm the diagnosis of glaucoma, we must report the same findings as those reported for neonatal onset glaucoma at the time of birth, with emphasis on progression. So, if we're going to do surgery, which type of surgery? Well, there are multitudes of procedures described for childhood glaucoma, including angle procedures, segmental, both ab interno and ab externo, circumferential procedures that we've seen along the day, both ab interno and ab externo, and even a combination of ab externo and ab interno, filtering surgeries, both incisional, penetrating or non-penetrating, glaucoma drainage device. We have just to emphasize that filtering procedures alone yield an inferior result compared to other procedures that involve angle procedures as well, and hence are not currently recommended. And of course, combined angle and filtering procedures remain a very valuable tool for attacking childhood glaucoma. And if there are other anomalies in the eye, that is a secondary glaucoma, we follow the same treatment paradigm, but we know that the outcome is worse. So the literature is rich with studies describing surgeries in childhood glaucoma, including segmental ab interno goniotomy, ab externo trabeculotomy, ab interno goniotomy by suture, ab interno goniotomy by knife, ab externo trabeculotomy by catheter, ab externo angle surgery, combined filter and angle surgery, and glaucoma drainage devices. Collectively, the reported success rate for these procedures is, for the primary surgery, somewhere between 80 to 90%, and for redo surgery, somewhere around 60%. This sounds really a serious disease. Is there any tool that can help check if my child has it or not? Well, there were attempts to identify childhood glaucoma based on periocular photographs with a sensitivity of almost 80% and a specificity of 94%, although these were carried out on Asian eyes. But the accuracy was comparable to pediatric ophthalmologists and glaucoma specialists, and even outperforming average human examiners in the detection of childhood glaucoma. No, my child's eye are looking good again. Could this be possible, sir? Well, one study reported 12 out of around 506 eyes demonstrating spontaneous resolution of primary congenital glaucoma. So can it happen? The answer is yes. Past the third year, my child is becoming a lovely toddler, then an adorable, stubborn teenager. My youngster is suffering at school. I don't think he's seeing well. Well, maybe he's suffering that type of glaucoma occurring to juveniles. Juveniles? What is this about juvenile glaucoma? It is something that can occur at any time between the third year to the end of the childhood years, 18 or 16 as we've mentioned. But we know that the eye will not grow under the influence of elevated intraocular pressure. And the prevalence is quite variable in different populations, from as low as 0.7 in Caucasians to as high as 3.4% in some places in Nigeria. It is generally silent. We need to measure the intraocular pressure because it is a high tension glaucoma, although there are a few reports or a few series of juvenile normal tension glaucoma. Confirmation of the diagnosis is done by optic nerve examination and visual field changes for those reliable children. Gonioscopy will reveal a normal angle in up to 1/3 of the cases, although goniodysgenesis will be apparent in 2/3 of the cases, and myopia is a common association. Looks like you're doing a good job, but are you sure my child's eyes are actually better? That is there any objective test to confirm that my child's eye is good? Well, there are indirect clues, ma'am, to tell us if your child's eye is doing good or not. So the visual evoked potentials, what we know about them is that they are affected in childhood glaucoma, and they improve with successful control of the disease. And children who grow older with controlled disease have VEPs that are almost comparable to other age-matched normal children. And although your child is probably doing good, there is definitely some suffering, which may be related to health, may be related to vision, and may be related even to functional vision. So, for example, these factors are associated with the worse quality of life of your beloved son or daughter. They may be clinical, socio-demographic, among others. So the clinical factors are a long list, the socio-demographic factors are another long list, and the others, introverts among extroverts, are other causes of suffering of your child. So thank you for taking care of my child in his early years. It's been quite a journey so far. You've done a great job as parents as well. You can't imagine what you've been through. What I've been through, life has been just okay. Not quite much okay. You may have not noticed that you've suffered with the diagnosis journey, the treatment burden, navigating the healthcare system, impact on family life, coping and resistance and resilience, unmet needs and recommendations for system improvement. But luckily enough, we're very thankful for these coping mechanisms that have helped you, which include religious faith and praxis, peer support networks, information seeking, focusing on positives, professional psychological support, advocacy activities, and compartmentalization of your problems. So these issues have helped you significantly navigating the very long and difficult path with your affected child. Attention, we're not done yet. Your youngster may not see the same way we do or you do. How's that? Well, what you know about the visual function of childhood glaucoma children is that their average visual acuity is about 0.44 decimal, that is about 6/12 Snellen. The refraction is generally around the 3.5 of myopia and the 2 cylinder, with the visual function naturally being dependent on the cornea, the lens, and the aberrations. So for the cornea, we know that the thickness is decreased to about 500 microns. Strangely enough, HABs stria do not cause any difference in corneal astigmatism, at least, with the AC depth, of course, increased. The lens changes that are reported in childhood glaucoma include cataract incidence in more than half of the cases in which the lens is affected, and lens subluxation in 1/3 with zonular injury, about 7%, and actively lens pathology occurs in about 9% of children with childhood glaucoma. So what about aberrations? What does the eye tracy tell us about childhood glaucoma eyes? Well, there is 4 times the total amount of corneal aberrations, and the higher order aberrations, the most common being the coma and the trefoil. So, can anything be done to improve my poor youngster's vision? Well, spectacles, we believe, is the best and most conservative option and the safest so far. Contact lenses are contraindicated if filtering surgery is there, because the presence of a conjunctival lesion will contraindicate the use of contact lenses. Refractive surgery, corneal lamellar surgery, makes the measurement of the intraocular pressure in the future and follow-up almost difficult, almost impossible, so I believe it's relatively contraindicated. And for lens surgery, we have to remember quite well that any intraocular surgery risks the recurrence of intraocular pressure elevation and secondary retinal pathology. Finally, my young man has finally found the soulmate and is tying the knot, and the journey starts all over again. So my take-home message is, true love is worth every battle. And thank you very much for your attention.
Good evening, all. It's a pleasure to be among you today. I'm going to talk today about the glaucoma solutions offered by Orchimedia Pharmaceutical. Orchimedia Pharmaceutical is one of the leading pharmaceutical companies in Egypt, which has a very large and versatile portfolio for glaucoma. So I'm going to show 2 scenarios for 2 patients and how we can use the versatile portfolio to help the patient. So scenario number 1, an old age patient which was diagnosed with primary open-angle glaucoma with intraocular pressure of 26 millimeter. It's his first time, so how will you manage this patient? I will usually start with preservative-free prostaglandin eye drop, like the Taflopro, which offers 31% IOP reduction. Other alternatives are the preservatives, like the Travanorm or the Travanorm Plus. The Travanorm is a monotherapy, which reduces IOP reduction of 25 to 28 millimeter Hg, 28% reduction, and Travanorm Plus, which is Travoplast with beta blocker combination, which can be used once daily at night and offers IOP reduction of 32%. Actually, they may cause some hyperemia, which is mild and transient. It is convenient, and it can be used for once per day at night. So we offer the patient the benefits of reduced IOP, improved compliance, and better visual preservation. Back to scenario. After 2 years, the patient came again with IOP elevated to 22 millimeter Hg with a progressive optic nerve damage. How will you manage? Actually, we can add an eye drop like the alpha benzema twice daily to achieve 30.9% reduction. It has a dual mechanism for glaucoma and optic nerve protection, and it is the only available brinzolamide bromide fixed combination in Egypt. And its dose is twice daily. Scenario number 2 is a 65-year-old patient on anti-glaucoma treatment for 2 years, and this is a picture of his eyes. He is complaining of severe dryness, conjunctival injection, decreased marginal tear film strip, and frothy discharge, and he is on preserved prostaglandins and preserved carbonic anhydrase inhibitor with beta blocker combination. How will you manage such a case? For me, I would stop the anti-glaucoma treatment, then treat with carbonic anhydrase inhibitor tablets, 250 milligrams, 4 times per day, with a preservative-free steroids and preservative-free lubricants. Then I will shift the patient to preservative-free drops in the form of combined beta blocker carbonic anhydrase inhibitor, single dose units as Twinzol, and the prostaglandin single dose units as the Ioprost, and a lubricant single dose drops 3 times per day. And after 1 month, the patient came and was satisfied. If we're going to talk about the Twinzol, the bottled or the preservative combination, it's dorzolamide and timolol. Both agents reduce the aqueous humor production, and the dorzolamide may improve the ocular perfusion, and the timolol decrease the episcleral venous pressure. And we use it in primary open glaucoma, ocular hypertension, or post-operative eye bags. So, to sum all of the Orchidia portfolio, prostaglandin analogs like Taflopro, Taflopro Plus, Ioprost, and single doses and bottle, Travanorm Plus and Travanorm. Fixed combinations like the alpha benzema, Twinzol single doses, and Alpha Nova Plus, and alpha agonist like the Alpha Nova, which is a very versatile portfolio for management of glaucoma. And thank you so much.
تينا ياسمين طب نبتدي لحد ما يجوا. استاذن حضراتكم في السيشن اللي احنا موجودين فيها ديت انجل سيرجري اب انترنال كانال بيز بروسيدور. نبتدي باستاذ الدكتور طاهر رجائي to talk about tips of ab internal angle surgery. طارق.
Dear professors and colleagues, today I'm going to talk about tips of ab internal angle surgery. In Schlemm canal-based surgery, better outcome can be achieved in glaucoma patients whose pathology is in the trabecular meshwork. For example, primary open-angle glaucoma, pseudoexfoliation, primary congenital glaucoma, juvenile open angle, and steroid-induced glaucoma. These are some indications for the canal-based angle surgery. The first step in ab internal angle surgery is getting started with surgical gonioscopy. As we all know, gonioscopy is used to classify and diagnose glaucoma at the slit lamp in all patients with glaucoma. Using the surgical gonioprism requires a higher skill level because it requires the use of gonioprism mirrors under an operating microscope to visualize ocular structures that require treatment. This particular skill requires more manual dexterity because the surgeon must use one hand to balance the gonioprism on the cornea to permit visualization of the structures requiring treatment, and simultaneously the second hand to carry out the procedure. Angle surgery is working in even smaller, more sensitive space within the eye, which is the trabecular meshwork, approximately 0.7 millimeter width. These are some tips for getting started with surgical gonioscopy. Office-based gonioscopy will facilitate the preoperative planning. Fixation ring used during phaco surgery will help you for bimanual use. Peri or retrobulbar anesthesia, kinesia will help you during the angle surgery. Also, after routine cataract surgery, this provides familiarity with the head and the microscope rotation. Diffuse red hue of blood in the Schlemm canal helps identifying the trabecular meshwork. Also, in minor OR, practice gentle docking of gonio lens on volunteers and online resources. The second tip in ab interno angle surgery is the types of surgical gonio lenses you need to be familiar with. There are two types. Several surgical gonio lenses needs head position of the patient away from the surgeon and the surgical microscope towards the surgeon for approximately 30 to 35 degrees. Oblique coaxial illumination and angle viewing, like with the Swan-Jacob gonio lens, requires head and microscopic tilt. On the other hand, some surgical gonio lenses eliminate the need of any head or microscope tilt, like the Ahmad direct view surgical gonio lens. Here, with two internal mirrors, allow coaxial angle viewing. There will be image of the small mirror in the large one, so no need for microscope or head tilt. The third tip in ab interno angle surgery, how to identify the Schlemm canal, how to identify the area of the trabecular meshwork, and the Schlemm canal is behind the trabecular meshwork. There are three methods. Pigment, moderate to heavy pigment provides a natural visual guide, and the areas of greater pigment indicate close proximity to the collector channels. As we see here, this is the trabecular meshwork in gonioscopy. Number two, blood. Blood in the Schlemm canal. Provocative gonioscopy, forced reflux into the canal of Schlemm occurs after relative hypotony. Blood will reflux into the Schlemm canal with IOP drop. And this is what is usually seen in viewing the angle after phaco surgery or during ab interno angle surgery. Number three, Trepan blue, non-toxic to the trabecular meshwork when applied for less than 6 seconds and diffusely stays the trabecular meshwork. These are the three methods by which you can identify the canal of Schlemm. There are some technical tips. Number four, too much pressure on the gonioprism will get corneal striae, which will block your view, and too little pressure will get air bubble in the cornea gonioprism interface, and you will have difficulty view or no view. In the learning curve, use a blunt instrument like iris spatula or blunt cannula to touch the trabecular meshwork to be familiar with the position and the handling of the trabecular meshwork in different technique. Here in this short video, after I have finished the case of phacoemulsification, I am starting to learn how to see the canal and how to do this by manual manipulation, touching the canal while holding the gonio lens. This is a direct view gonio lens under viscoelastic on the cornea. putting it on the cornea, and as you see here, the blood in the canal of Schlemm will start to appear, and I will do more magnification. It is more clear here. Here's the blood in the canal of Schlemm. After this training, get the lens off, and I put a blunt in here. Clear the area you will work for surgery, for the ab intern. Then I use blunt instrument like the iris spatula, and again apply the lens and start to just touch the canal like that. By this training in the learning curve, you can deal with this by manual work and how to work ab internal angle surgery. Number 5, post-operative sign of success. White appearing cleft noted after trabecular meshwork excision. Here is a trabecular meshwork after excision on follow-up on gonioscopy for the patient on the slit lamp. You will see this white appearing cleft. This is a good sign for ab internal successful trabeculotomy beside IOP control, and thank you.
Thank you much, Dr. Tariq. Now may I call on Omar Mehdi to present?
Good evening all. It's a pleasure to be among you today. I want to thank the organizing committee for inviting me for this prestigious Okay, my talk today is about 2 cases. The first case is a 73-year-old man presented to the clinic complaining of diminution of vision in both eyes. Medically, he was hypertensive, non-diabetic. He was diagnosed with glaucoma 20 years ago and was on topical beta blocker, carbonic anhydrase combination, and travoprost drop. His best corrective visual acuity in the right eye was 0.6, in the left was 0.7. He had pseudoexfoliation in the right eye with nuclear cataract in both eyes. By gonioscopy, in the right eye, open angle with pseudoexfoliative material. In the left eye, open angle with no pseudoexfoliative material. Cup disc ratio 0.9 in the right, 0.6 in the left. IOP was 20 millimeters G in the right, 15 in the left, with finished cornea in both eyes. This is his visual field. You can see how severely damaged the optic nerve. And this is the OCT optic nerve head showing decreased nerve fiber in both eyes. So after discussing with the patient refused to do any filtering surgery. So we offered him to do a combined phaco and Cahoop dual blade, and the risk and benefits were explained. So let me first, what is the Cahoop blade? The Cahoop dual blade is one of the many invasive glaucoma devices present. It is has a pointed tip which can pierce the trabecular meshwork, and a ramp to elevate the trabecular meshwork, and 2 cutting edges which cut the trabecular meshwork as a whole. So it does an excisional goniectomy, not a goniotomy. It has a rounded heel so as to move freely on the trabecular meshwork. It can be done as a standalone procedure or a combined. Standalone in mild to severe open-angle glaucomas, and secondary glaucomas as pseudoexfoliation and pigmentary glaucoma. Combined procedure in angle closure or cataract associated with open-angle glaucoma. Contraindication is poor visual, for poor gonioscopy view, uveitic glaucoma, increased episcleral pressure, and neovascular glaucoma. In literature, this is 12 months outcomes for procedure, and it showed decrease in the pressure by 22% in 3 months, in 1 month, and 27 in 3 months. Sorry, 22% in 3 months, 27 in 6 months, and 19.3 in 1 year follow-up. And with phaco, it decreased the pressure around 47%. This is the video after finishing the phaco. We put a viscoelastic, we identify the angle with a direct goni lens, introduce the Kahoot blade, and then we pierce the trabecular meshwork and move along the trabecular meshwork. You can see how we're going to pierce the trabecular meshwork and then move to cut or remove the trabecular meshwork. We do one side and then rotate the Kahoot dual blade and the other side. Actually, it does around 90 degrees. And if you can see here, you can see the trabecular meshwork strip coming out. The video of the other eye, it's a little bit magnified, so I'll pierce the trabecular meshwork and move along the trabecular meshwork. It may not be a little bit, the video is a little bit fuzzy here, but on the other side, it will appear more. Okay, I'll pierce the trabecular meshwork and move along, and then rotate the Kahoot dual blade, and then do the other side. And here you can see the strip of the trabecular meshwork coming out. This is some blood may come out from the trabecular meshwork. First day postoperative, the pressure in the right eye was 8 millimeter Hg without drops, and in the left eye was 18. So we added one drop for a 1 week. And after 3 weeks, the pressure was 12 on no drops and 10 millimeter Hg in the left without drops. We added one molecule for the right eye for the sake of the advanced glaucomas in the right. This is another case, 53-year-old woman, single-eyed. Pressure was 30 millimeter Hg on maximum treatment, closed angle, and cup disc ratio was 0.9. So the decision was to go for phaco, conius and Kahoot dual blade. After finishing the phaco, which was straightforward, implanted the IOL, and now doing gonius with viscoelastic. But this happened. The nurse, while giving me the Coke, fell on the ground. So it's not sterile. What we're going to do? Actually, no worries, we can do a bang. So what is the bang? The bang is a bent ab-internal needle goniectomy. This is a cheaper version of the Kahoot. It is introduced by the Indians. We use a 23 to 25 gauge needle and we bend it 30 degrees to 90 degrees on the tip, and we use it as a Kahoot to cut through the trabecular meshwork. In literature, this is the outcomes. It actually decreased the pressure by 31%. And we continued with the patient. We bent the needle and introduced it to the trabecular meshwork. And we can see the blood through the Schwanz canal, and we cut the trabecular meshwork. Actually, it gives less due to the small tip of the end needle. And we advance and cut, and that's it. Postoperatively, the pressure first day was 12, and after 3 weeks, the pressure was 14, and also we added a combination drop for the sake of she was single-eyed with advanced glaucoma. And thank you so much.
Thank you very much. I'd like to invite the next speaker, who is Dr. Rakaya Radwan, to speak. Thank you.
Good afternoon, ladies and gentlemen. It's Ruqayya Radwan. I'm pleased to be presenting today in the Egyptian Society for Glaucomas, thanks to the opportunity by my dearest Professor Dr. Yasmin Said. A diamond in the rough can be a gat in a refractory case, and this is a case presentation about a 48-year-old male who is has free medical surgical history. He presented with uncontrolled intraocular pressure despite full topical treatment for medications and Sedamax. So this patient presented with this uncontrolled intraocular pressure with his examination showing the following. The right eye showed corneal epithelial edema while there was a clear cornea in the left eye. His intraocular pressures were 45 and 26, and his center cornea thickness was a little bit thick, 601 and 597. And his gonioscopy revealed the open angle bilaterally, and posterior segment showed advanced cupping in the right eye of cup disc ratio of 0.9 and the left eye of 0.6. His best corrected visual acuity was 0.2 and 0.7. So the plan was to do a right deep sclerectomy because this was the more advanced eye. And the deep sclerectomy was done. But post-operatively, the IOP kept at 40, and the corneal epithelial edema is still the same. Massage was tried for a few days, but with no success. Later, the patient was brought again on full topical treatment, but still the IOP was the same. So, a right trabeculectomy with mitomycin C was done, but the epithelial edema was even worse, and IOP kept at the same range. Cupping was progressing. At the same time, the other eye, the better eye, was showing an IOP of 54 millimeter mercury. Maybe this patient really has a terrible compliance. So the plan was to do a right cyclodiode and a left Ahmed glaucoma valve. So the primary valve in the left eye aimed for maybe protecting this eye from the fate of severe uncontrolled intraocular pressure. But will this work? Let us see. Postoperatively, after the valve, the intraocular pressure was 35 millimeter mercury and dropped to 12 millimeter mercury on 3 medications. Then, at 3 months, IOP is 35 in this eye, in the better eye, on the same medications. So, left GAT was done 3 months after Ahmed glaucoma valve. To our surprise, for the first time, this patient had a controlled intraocular pressure, and his IOP was 15 on one medication since then. Back to his right eye, the terrible eye. Throughout the follow-up, after the deep sclerectomy, trabeculectomy, the diode, IOP was 40s, and the patient even lost follow-up after a while. And he returned back with intraocular pressure of 50, cupping of 1. His visual acuity, unfortunately, dropped to counting fingers. But if one eye after GAT is controlled, would this be beneficial for the other eye? Maybe. So a right GAT and needling was done for this eye. Again, his IOP is controlled. And now his IOP is 14 and 15 on one medication. So collectively, these are the surgeries for the right eye and those for the left eye. Upon review of literature, outcomes of GAT have been previously discussed by Gruber et al., and they had 35 eyes which were reviewed after performing GAT after previous incisional glaucoma surgeries. 19 eyes had previous trabeculectomy and 13 had previous Ahmed glaucoma valve, and they had significant reduction after performing GAT in these patients. They concluded that GAT can be actually beneficial in patients after performing the traditional gold standard surgeries as trabeculectomy. Of GAT and advanced glaucoma have been also discussed before. A report published this year showed that GAT is safe and effective alternative to trabeculectomy, even for advanced glaucoma, and they performed their analysis on 45 eyes. So my take-home message is that GAT can reverse the order. It can be a diamond that can help after really big operations that we know them as the gold standards. And future research should focus on these challenging cases to prove the efficiency of GAT and its non-inferiority in such cases to big procedures such as trabeculectomy and Ahmed glaucoma valve. So these are my references. I have special thanks to Dr. Fayrouza Belazem for her help and continuous support. I'm really grateful for her. That's all, and thank you.
Thank you, Dr. Aya. Now, Dr. Ahmed Louhedi, you are welcome to talk about optimal therapy.
Good evening. Assalamu alaikum. My presentation is titled, What is the optimal angle surgery for primary congenital glaucoma, and evidence-based analysis of 4 techniques. As we know, primary congenital glaucoma is a sight-threatening developmental anomaly of the anterior chamber leading to elevated IOP and optic nerve damage. Operating such patients needs extreme precision. Surgery is a mainstay of treatment aiming to improve aqueous outflow. The angle surgery, whether ab interno or ab externo, is a cornerstone for treatment of pediatric and primary congenital glaucoma in particular. Why angle surgery is a cornerstone in primary congenital glaucoma management? First line intervention, which has the highest success rates, directly targets the site of anatomical obstruction, aims to restore the eye's physiologic drainage mechanism, offering the potential for long-term control. Angle surgeries includes two categories. Ab externo angle surgeries, whether segmental by rigid group trabeculotomy or circumferential using microcatheter or Prolene suture. The second limb of angle surgeries are the ab interno angle surgeries. All are not suitable for children with cloudy corneas. As conventional goniotomy, Cahook double blade segmental ab interno trabeculotomy, and get gonioscopy assisted transilluminal trabeculotomy. With these multiple angle surgeries, which one is a more suitable, more effective, more safe, more practical? We have published 3 articles. The first one in 2020 in European Journal of Ophthalmology, comparing between conventional trabeculotomy and viscotrabeculotomy. The second one in Journal of Glaucoma, comparing between 2 types of ab externo trabeculotomy, segmental using rigid group trabeculotomy and circumferential trabeculotomy. The third one this year, also in Journal of Glaucoma, comparing between ab interno circumferential GAT and ab interno circumferential GAT and ab externo circumferential trabeculotomy congenital glaucoma. From these articles and other articles in literature, we can conclude that the first technique, conventional trabeculotomy, this classic technique can be performed with a cloudy cornea, well-established familiar technique, has a low cost and also considerably successful technique. Hyphema is high in such patients. Also segmental, no read more than 180 degrees. Viscotrabeculotomy, we add after the roofing of Schlemm's canal, we can inject halon to dilate the canal. This add in this technique has the advantage of significantly reduced hyphema, significantly lower IOP than conventional one, facilitates probe insertion and confirms canal location, higher success rates than conventional one. While some disadvantages as transient IOP spikes due to slow viscoelastic clearance and the cost of viscoelastic material. The third technique is ab externo circumferential visco circumferential trabeculotomy. We expose the canal of Schlemm by, I prefer the two flap technique. The first flap, then the deep flap, to expose the canal of Schlemm, and then introduce a proline suture of 5-0 until the other end coming from the other end of canal of Schlemm, then complete trabeculotomy. This technique advantageous in cutting the trabecular meshwork for 360 degrees, superior in IOP reduction, lower cost than using microcatheter, and has a high success rate, while some disadvantages as being more invasive than GET and has rarely a risk of false passage. I can use this technique also even in difficult cases as neonatal onset primary congenital glaucoma, where GET cannot be done due to opacity of the cornea. The same technique, reaching the canal of Schlemm, complete trabeculotomy is done in these cases. Last technique is the GET. GET is the ab interno circumferential trabeculotomy using proline suture or microcatheter then through a clear corneal incision. It has many advantages, especially preserving the conjunctiva and minimally invasive. Can be done especially with cases with phacoemulsification. Some disadvantage in primary congenital glaucoma that it requires a clear cornea for angle visualization. Not suitable in advanced primary congenital glaucoma, not suitable for severe angle dysgenesis, requires expertise in conioscopy and angle surgery. So in this table, we can observe the high success rate, especially in the circumferential techniques, whether ab externo or ab interno. So the optimal procedure depends on corneal clarity, costs, and the availability of surgical facilities, surgeon experience, goal for the eye, and extent IOP reduction. So ab externo circumferential trabeculotomy is suitable for cloudy cornea. GET is suitable for clear cornea. Less experienced surgeon, it is better to follow the rigid trabeculotomy. When we need maximal IOP drop, circumferential trabeculotomies can be done whether ab externo or ab interno. Now, home messages. Conventional trabeculotomy is the historical standard technique. Viscotrabeculotomy has a significant improvement over conventional, offering better IOP control and fewer bleeds. Circumferential ab externo trabeculotomy provides excellent sustained IOP control via 360-degree trabeculotomy and is the optimal ab externo choice when corneal clarity is poor. GET offers comparable efficacy to circumferential suture trabeculotomy with the advantage of being minimally invasive and conjunctival sparing, making it the optimal ab interno choice when the cornea is clear. So, final take-home message. There is no single best technique. The optimal trabeculotomy for primary congenital glaucoma is determined by a triad of corneal clarity, surgeon experience, and the long-term surgical plan for the child's eye. Thank you.
Thank you very much, Dr. Ahmed. Next, may I invite Dr. Hazim Helmi to present?
اهلا وسهلا بحضراتكم. Thank you, Dr. Yasmin. I will talk about deep sclerectomy, a new approach. What about deep sclerectomy? It is a non-penetrating glaucoma surgery, non-bleb forming. The filtration occurs through the trabecular distance window, and so it is highly controllable. Depends upon intrascleral and suprachoroidal infiltration. Why deep sclerectomy? Why I have to choose deep sclerectomy? Less complications like hypotony, less cataract progression, bleb complications are minimal, safer in advanced cases, less incidence of endophthalmitis, and faster recovery of visual acuity. Advanced glaucoma case, our big challenge. What can we do and what is the choice, the right choice for surgery? We are searching for effective and safe maneuver. We are afraid from the hassle of wipeout and the cataract progression. And so deep sclerectomy may be a good choice. But deep sclerectomy alone promotes moderate reduction of intraocular pressure, as we know in our practice. So augmentation is mandatory, especially in advanced glaucoma cases. How to augment the effect of deep sclerectomy? Multiple studies, multiple trials are present with variable results, started by mitomycin, skier implants, combined between deep sclerectomy and another surgery like Zengel or trabeculotomy are very common nowadays with variable results. Implants have a long history. Multiple implants were tried with multiple results and variable results. In our department in Rio, we have a long-term experience with mitomycin C and amniotic membrane implantation, which provides anti-proliferative, anti-inflammatory, and anti-fibrotic agent to prevent adhesions and to prevent obstruction, and in a trial to maintain the patency of the intrascleral pocket and filtration along the suprachoroidal and the conjunctival visits. But now we are shifting to a new current recent approach, deep sclerectomy, augmented with mitomycin C and hydroxymethyl methacrylate implant, in addition to tenonectomy, excessive tenonectomy to reduce fibrosis. I have no financial interest. This is a case of pseudophakic glaucoma. We are performing deep sclerectomy, wide conjunctival dissection, tenonectomy, elevation of superficial scleral flap, half thickness of the sclera, formation of deep flap, minimal tissue over the choroid have to be left in order to get this excellent perfusion of fluid through the trabecular Descemet's window, excision of deep flap, implant, insertion, closure, of the superficial flap, mitomycin application, as usual, closure. Of the conjunctiva, and this is the net result after 1 month. A good intrascleral pocket is present patent detected by UBM. Tension 10 millimeter mercury without any treatment. Rapid rehabilitation of the patient and return to his ordinary life with ease. Preserved advanced optic nerve, which was highly advanced semi-terminal. Augmented deep sclerectomy is a good option in advanced glaucoma cases. Mitomycin application, kinonectomy, and scare implant adds highly valuable benefit. But the success of this procedure highly depends on accuracy and professional technique. Thank you.
Thank you very much, Dr. Hazem. I'd like to invite my co-chairperson, Dr. Yasmin, to wrap up with the last talk.
Thank you. Angle-based surgeries are often looked at as minimally invasive glaucoma procedures, in another sense, minimally effective, and are only reserved for mild to moderate glaucoma, but you'll be surprised how much they can come in as lifesavers. There have been a lot of, Dr. Roqaya has presented a beautiful case where this is an actual proof. And actually, I have my own case. The reason why I shifted almost exclusively to angle surgery for adult glaucoma patients now over the past 5 years was this 76-year-old pharmacist who presented to me back in 2019. He was a very grumpy patient. I described him to AI, and this is the closest to what he actually looked like. A very anxious, skeptical patient, and he was justified actually. He had lost his right eye to retinal detachment. His left eye was left aphakic. His vision was 660, was with what I think was a single nerve fiber left in there. He had a very advanced primary open-angle glaucoma. His pressure was 18 on full topical meds, acetazolamide 3 times a day. He had multiple previous glaucoma surgeries, an AGV back in 2014, and then finally a Barveld implant a few months before he came. The surgeon had left the stent in there, it wasn't removed, and left the country afterwards. So the plan when I saw him was to go in and remove the stent, probably bring down the pressure to the low teens of acetazolamide. And I went in there and looked all over the place around these card fornices for a stent, and it wasn't in there. And I remember I unscrubbed on that day and phoned the actual surgeon in London and asked him, where did you keep this? And he was like, no, Yasmin, it's there. Go back and look for it. And I went back and it wasn't there. All I could see was scarred conjunctiva all over that would never accommodate another fistulizing procedure. A diode CT would probably blunt out whatever he had left of the nerve with a spike. And so the only option was to do what I was doing back then in children, maximum extent incision trabeculotomy. At this point, we were doing trabeculotomy ab external in children using based on two sclera flaps 180 degrees apart to cover as much of the angle as possible. And in eyes that had previous straps or tubes, let's fashion the sclera flaps to be away from the problematic area of the blebs and fistulae, so as not to get engaged into the Schlemm's canal on this side. So I did that for him, around 270 to 300 degree trabeculotomy ab external, and his pressure went down beautifully to 7 on 3 meds. He wanted to use more and more meds. He was a pharmacist, he loved meds. I would have kept him at 8-9 on a combination therapy. And this was the last time I saw him post-operatively. I never heard about him, but I've seen the evidence in literature years later, and I've seen it from the patients that I've been doing since then, because like I said, I almost converted completely to GAT in patients who are suited for that, who don't have a lot of PAS that would result in adhesions. So this study was published a couple of years ago, and they included 44 eyes with prior glaucoma surgery. 80% had one prior glaucoma surgery and 20% had more. So these were patients that had multiple glaucoma surgeries and definitely had advanced glaucoma. And eventually at 2 years, the pressure came down to 15 meters mercury or less in 56% of the patients, with 61% of the eyes being off medication at final follow-up. A lot of other studies that have also looked at previous glaucoma surgery as a potential adverse prognostic factor in GAT failed to show any risk or adverse prognosis in patients who have glaucoma surgery. It seems that the angle is very forgiving, particularly that you're addressing a completely different side. In patients, just like Dr. Ruqayya presented, patients who would not do well with conjunctiva-based surgery. The conjunctiva is just not made for glaucoma surgery. You can address another pathway, and it comes to be the physiological outflow pathway, where most of the resistance lies at the level of the inner wall of the canal and the adjacent trabeculum. So you can do this through an ab external trabeculotomy, again, maximum extent incision. Maybe I think angle surgery was previously falsely or unfairly judged because we used to do a limited extent incision in adults. But with a bigger incision, a circumferential or a maximum extent, you can get marvelous results in eyes with previous glaucoma surgery, either through an ab external trabeculotomy or an ab internal GAT. So how about advanced glaucoma? Several studies have shown that there is no correlation between the stage of glaucoma and success of GAT. So it can fail in a mild glaucoma and succeed marvelously in a patient with very advanced glaucoma. Now, when it comes to secondary glaucomas, again, it's a life changer in a lot of those, particularly the steroid-induced open-angle ones. So uveitis, if primarily they're steroid-induced or whatever is blocking the angle in those eyes, responds very well to incisional angle surgery circumferentially. Even if they have some patchy PAS, you can clear those out initially to find the trabeculum so as to incise in the correct plane. Once you clear this clear spur, you can get your incision in the inner wall of the canal. And as an added plus, that in those eyes, as you can see here, when you pull on the suture, when you incise the inner wall of the angle, it also incises the peripheral synecdoche. And as you can see here, the iris is falling back in an area where you can visualize it, but also circumferentially in areas where you cannot access in order to cut off those synecdoche. So it creates a 360 incision, not only in the canal, but also in the PAS. And we've actually submitted this study. It's currently under review of 42 eyes, where we included eyes only with 2 quadrants or less, less than 2 quadrants of PAS. Most of the eyes were quiet, but we did not exclude those with activity. And we included several types of uveitis. This was the breakdown of the pressure control at 1 year and at the final follow-up. Overall, 95% of the patients were classified as successful with a pressure of less than 21 and or 30% IP reduction, and 55% were off medications. And again, when we looked at the influence of different factors, there were no adverse prognostic factors, including those that had previous tracts or tubes. They did not tend to do worse than those that didn't. Now, post-PKP glaucoma is another challenging glaucoma, basically because the surgical options we used to have adverse prognostic factors on the graft survival, as well as not having awesome success rates. So the success rates of trabeculectomies are variable, anywhere between 20 to 80%. Glaucoma drainage devices have slightly higher, better success rates, but they're more likely to have adverse effects on the graft. Of course, not all of them are placed so close to the graft. We're talking about the ones that are properly placed around on the iris plane. Even cyclodestructive procedures can have adverse effects on survival of the graft. On the other hand, GAT was studied in post-PKP eyes, in 39 eyes over 2 years follow-up, and the IP dropped from 30 to 13 on significantly fewer number of medications. 7 out of the 39 required another glaucoma surgery within the 2 years follow-up. But the great thing was that the effect on the corneal graft survival was superior to previous glaucoma surgeries. The need for repeat corneal surgery was 2.5% at 1 and 2 years and 40% at 3 years, which is much less than we see with previous fistulizing surgeries. Now, the procedure itself can be a bit challenging because of visualization. So if you have a centrally clear cornea, it's more or less a straightforward procedure, just like any case where you would do GAC. But sometimes the cornea is opaque and you need to find your way around the clearish bits of the angle. And sometimes the angle itself is not easy to visualize because of the shelf between the graft and host. So in this case in particular, I remember it was very tricky, although you could see the angle very well and it's open on the slit lamp with the Volgonio lens. Inoperatively with the Jacobs, it just falls in a dead space that is not visualizable, at least in the temporal with the temporal approach. And in this case, I had to shift to the inferior approach by bending the patient's head inferiorly towards the chest and adjusting the inferior angle. This is not always easy or accessible, particularly in patients with a high orbital ridge, but luckily in this case, it was doable. So GAT is worth a try, being blebless and more importantly, being safer on the graft before resorting to more invasive or filtering conjunctiva-based procedures. Finally, post-vitrectomy glaucoma has also been reported to be, GAT has been reported to be effective in several case series, including in siliconized eyes, where it can help clear out the Schlemm's canal of the silicon bubbles that are left in there with very reasonable outcomes. The take-home message here is when you find yourself stuck in between the vicious circle of transretinal tabs, tubes, diodes, always think back and look at the angle. It's quite forgiving and it has a very good chance of getting you out of this whole vicious circle and with very good success rates, even in advanced and challenging cases. Thank you very much.
Thank you, Dr. Yasmin, for the nice talk. Now it is
Assalamu alaikum. My first question for Dr. Omar, for the tissue that you cut with the KDB, do you remove it by stripping it or leaving it sagging in the AC? And for how long arc of length of the angle you are cutting?
Actually, I remove the strip. I can remove it. Or cut it with the needle, or we can remove it with a micro forceps. And for the angle, usually it's around 100 degrees. It's according to the main wound. I go through the main wound and then around 45 degrees here, 45 degrees there, and may cover it a bit from 90 to 100 degrees.
My second question for Dr. Tarek regarding this new gonio prism. Is it available in Egypt?
No, it is not available. I get it from outside, from the academy. It is Ahmed Direct View Surgical Gonio Lens from Ocular.
Okay, so this brings this session to the end, and next may I call on Dr. Sanjay Asrani to present the guest speaker lecture. I'm not sure if it's, we're a bit early, yeah.
Dr. Tarek. دكتور طارق ممكن تقدم المحاضرة بتاعتك لحد الدكتور سانجاي يجي. دكتور طارق عيد will talk about maximal medical therapy of glaucoma. سمعت؟
دكتور عيد.
نزل
دكتور عيد.
بعض.
بعد السيشن اللي بعد.
I'd like to thank the Egyptian Glaucoma Society for inviting me here. And actually, I'm here giving the talk about Farco pharmaceutical company. And our talk will be around the concept of maximal medical therapy in glaucoma. This is our outline talk today. And actually, we treat glaucoma mainly to slow down or stop progression of the disease by lowering the intraocular pressure mainly to a safe level and improve viability of the retinal ganglion cells to preserve patients' visual function without undue effects on his quality of life. And actually, this is the evolution of anti-glaucoma molecules over the past century. And before it was in the 19th century, it was pilocarpine alone, but starting from 1925 till now, 100 years, we have epinephrine, timolol, dorzolamide, and then primolidine and latanoprost, and then brinzolamide, travoprost, imatoprost, tafloprost. Finally, we have zolitarsudel in 2018. And we're starting now with the intracameral Duresta and travoprost. This is what we have in the glaucoma molecules. And we have some standard guidelines that we all follow for treating glaucoma. Identify the states of the glaucoma of your patient, and then identify the baseline intraocular pressure. Set a range of pressure, which is the target pressure we need to think about, and then select the therapeutic line to achieve this goal. After that, we do select medications regimen based upon its efficacy, safety, tolerability, and availability and cost. Then we check the response of the patient and the pressure to treatment. If not satisfied, usually we either switch or add more medications until we reach the maximally tolerated medical therapy. This is what we all follow. The current paradigm of medical therapy is customization of the treatment. The rationale is using the minimal number of drops with best efficacy and least adverse effects, and usually go for monotherapy first. We can go for molecular therapeutic trial. We usually switch rather than add, and stratify available drops. Usually start with first line drop, second line, third line, and so on. But the question is, regarding medical treatment, what is the end point? The trip to maximal medical therapy actually starts with giving first-line treatment, which is usually prostaglandins. Second-line treatment can be beta blocker. Third-line treatment, which is topical carbohydrate anhydrase inhibitors. Fourth-line alpha agonists. Fifth-line artichoke kinase inhibitors. Then myotics. Sixth-line, then seventh-line carbohydrate anhydrase inhibitors. So we can go for all these drops, medications for maximal medical therapy. Even we can have hyperosmotics, neuroprotectives, vasodilators. In maximal medical therapy, unfortunately, we don't have any consensus. There is no consensus. So sometimes we say we have 2 bottles is enough. But 2 bottles can mean 3 medications or 4 medications or even 5 medications. Sometimes say, well, the patient can still tolerate 3 bottles. 3 bottles can be 6 medications. And even we get patients with 4 bottles in their pocket. And these 4 bottles can be 4 medications, 7 medications, or even 7 medications plus Diamox and intraocular implants. So maximum medical therapy, actually, we should think about a consensus. Evolution of this consensus of defining maximum medical therapy, we used to have, and in the past, it's the tolerance of the patient, regardless the number of drug pills. And then we started to say, well, the patient can tolerate drops, but if the patient has to have carbonic and systemic carbonic anhydrase inhibitors, this would be considered maximal. And now we have 3 bottles regardless of medications. But the modern concept, as we see from the European Glaucoma Society guidelines, they say 3 medications regardless the number of bottles. And once they have 3 medications are not enough, then they will go for surgery or lasers. And actually, nowadays we have current practical concept is using 2 bottles with 4 medications because of the fixed combinations like the prostaglandin beta blockers and carbonic anhydrase alpha agonists. Also, we have a problem with the abuse of the medications, whether patients misuse or physicians for prescription. So we can see that increasing frequency of a drop, sometimes they will give the patients prostaglandins 2 or 3 times a day. Sometimes they give Diamox 2 tablets 4 times a day. Using 2 drops of the same class, like using latanoprost and travoprost for the same patient, or using dorzolamide and brinzolamide. Also, using 2 or 3 fixed combination drops all have beta blockers. It comes with the end of giving beta blockers about 6 times a day, which is too much for the patient. So what are the factors that affect our choice for maximum medical therapy? We have to remember that efficacy declines with increasing medications. Is not the reverse. Tolerability also declines. Adherence declines very much with increasing the number of medications, while cost and adverse effects increase much. Also, availability control our choices. And at last, we have to think about the patient's acceptance and physician judgment. In fact, we have a vicious cycle for this maximum medical therapy. Usually, we go for maximum medical therapy because of poor IOP control, and the target is not reached, which means disease progression, which means adding more drops with more side effects. More side effects means poor adherence to medications, and then we'll go for a vicious cycle. Also, patients with advanced glaucoma is another issue, because advanced glaucoma usually necessitate maximum lowering of target pressure, which means maximum medical therapy is not enough. And then you think about highly invasive glaucoma procedure, which will result in high complication rate, and the end result is unhappy patient. So what are the solutions about this concept of maximum medical therapy? In fact, we try to change the concept into a qualified success for IOP control. If your target pressure is not achieved with maximum medical therapy, take a step backward and stay with sub-maximal medical therapy. If you were using 4 medications for this patient, go back to 2 or 3 medications and then start to add another procedure. This another procedure can be a laser or less invasive glaucoma surgery to control pressure with minimal side effects. Actually, we will weigh the risk-benefit ratio of this combined approach. So we maximize the effect, in the same time minimize the risk. So if we think about maximum medical therapy or maximally tolerated medications, we try to forget about these concepts and think about optimum glaucoma management, which will constitute submaximal medical therapy plus a laser procedure like SLT or subcyclo or micropulse, and another less invasive glaucoma procedure like MEGS. Also, lifestyle modifications and systemic treatment. Thank you very much.
How Sultan Muslim? Wait. Now we will go to the OCT peer control glaucoma diagnosis and progression by the JRs. Welcome.
Thank you. Thank you for the opportunity to go and visit more of Cairo this afternoon. So, let me share with you the principles of how we use imaging for glaucoma diagnosis and management. Because the dream of every glaucoma specialist is to turn off the visual field machine, never put it back on, right? Because every patient hates it, every technician hates it, every doctor hates it. We want an objective method. We want a hemoglobin A1C to be primarily from the machine spectralis, which is made by Heidelberg Engineering, and again, don't have any financial relationship. First of all, establishing a diagnosis of glaucoma. You know, the difficult look at one optic nerve, then we cross over the nose to look at the other optic nerve. By the time we have forgotten what the first optic nerve looked like, because thousands of have gone through our head. So this is the first time we are able to see both the optic nerves side by side. And when you see them side by side, you realize that, oh, there is a significant amount of size asymmetry, which is responsible for the cup asymmetry. And then you measure the nerve fiber layer tissue thickness around it, then you see that the measurement is actually symmetrical. And therefore, it is normal. And it's not, it's physiologic cupping. Now, when we look at these reports of the OCT, we do the circle scan around the optic nerve in the spectralis. It is laid out here. It is measured against a normative database, and it is then given to you as an average of sector thicknesses. So most people who look at OCT reports tend to gravitate towards what I call kindergarten ophthalmology. Kindergarten means you're looking at blue, green, yellow, red colors. We are not interested in colors. We are interested in this, the black and white. That is where there is a difference between the right eye and the left eye. And you can see wherever there is the difference, that is where the glaucoma is, because there is one principal glaucoma, asymmetry. So it is only at the end stage of both eyes will there be symmetry. Otherwise, there is almost always asymmetry in glaucoma. Before I go there, I also want to show you one thing, that not only can you see this, you can also see where the tissue is lost. You can also see here, there is a loss of tissue in the red-free image. Now, one of the most critical aspects of glaucoma measurement is not the nerve fiber layer, but the macular thickness. And when I proposed it in 1995, I was called silly and all sorts of names because the macula be involved in glaucoma. Now it is taken for granted. Of course, the macula is involved in glaucoma because the ganglion cells have died. But in 1998, nobody believed our paper. Nobody believed that the macula could be damaged in glaucoma. But here is a glaucoma suspect with a normal visual field. We created a asymmetry display between the two eyes. And we found that this place here, right minus left, is showing you where there is a problem. And then when you look at the 3D reconstruction of this OCT, you see where the gutter is, where the nerve fiber loss is, and you can see where it dips. And if you were to do kindergarten ophthalmology, you would be misled because the green is telling you everything is normal, when everything is not normal. It is only a sectoral average. That is why it is looking as normal. Now, to establish a diagnosis, we look at various things. We look at where the nerve fiber layer is pinched, where it drops into the abnormal. It corresponds to the superior paracentral defect. There is a loss of macular thickness, which is corresponding exactly to that same location. But here you're seeing it without a normative database. So now there is a normative database for the macular thickness, and you can see the nerve fiber layer thickness is lost and the ganglion cell thickness is lost. How about myopia, high myopia? When you see high myopia and you got these peripapillary atrophy, that confuses the software. The software cannot identify the nerve fiber layer correctly. Therefore, you look at the raw image. If you see the raw image is normal from here to there and here to here, that is superotemporally, that means the possibility of glaucoma is very low. Because you can see this thickness is near normal. There are some other rules that I'm going to share with you by some examples. This is where you can see a nerve fiber layer thickness is very low and then suddenly becomes normal. Same thing, macular thickness, extremely affected in the superior half, but lower half is near normal. Visual field is affected in the lower half correspondingly. When you see something which has a horizontal cut, it is a vascular event. One half is gone, other half is normal. This is a non-arthritic ischemic optic neuropathy. This case is a 22-year-old female diagnosed with advanced normal tension glaucoma. First of all, normal tension glaucoma doesn't occur in very young people, but can you see that in this case, it is not really glaucoma. This patient was being treated with 4 eye drops. This is not glaucoma. Why is it not glaucoma? Despite a visual field defect, macular thickness defect, nerve fiber layer defect, it is not glaucoma because there is extreme symmetry. Can you see how the right and the left eye are very symmetrical? So this is segmental disc hypoplasia. The upper half of the nerve did not develop. And then you see something exactly the opposite. This is extreme asymmetry. You see where the nerve fiber layer is lost, nasal. Where the nerve fiber layer is lost, temporal. Whenever you see extreme asymmetry again, it may not be glaucoma. What is it? Homonymous hemianopia. And you can see that on the macularness. You can see the vertical cutoff. That tells you that this is a slow growing mass or lesion. Why? Because the structure is already affected. So slow death of the ganglion cells tells you this is a slow growing lesion. Another rule to remember in glaucoma is until the glaucoma reaches the advanced stage, the nasal and temporal regions don't get affected. So whenever you see a temporal loss, an eye that doesn't have advanced glaucoma, think neurological. So here is a patient, again, inferior arcuate scotoma, superior loss of macular thickness, superior loss of nerve fiber layer thickness. But because there is still loss, we did the blood test and it was neurosyphilis. Now glaucoma progression, which is what we all want to look at, with this Cirrus machine. This is the machine made by Zeiss. This is where you get 2 baselines followed by the 2 subsequent measurements, which are subtracted from here. And you can see the probability of something being abnormal in that region or has changed. You can see that in the values also given to you in color code. You also see with this, which is the Zeiss machine, that the nerve fiber layer is thinning out. The macular thickness is also thinning out. And you can see where it is really abnormal. This macular thickness is not total macular thickness. This is ganglion cell inner plexiform layer only. I don't use this. I don't use this because I have to then depend upon the machine telling me which is the ganglion cell layer, which is the inner plexiform layer. When I look at it, I cannot confirm. So when I cannot confirm, I don't like the results that the machine is giving to me. I like the total retinal thickness because I can see and confirm it. How do I use the spectralis? So this is the baseline measurement, first measurement, second, third. So this third is subtracted from the first, and you can see where the pink area is, that's where the loss of tissue is. You can see where the tissue is thinning. And you can see it on the macular thickness. This is the first one, this is the second one. And you can subtract the two, and you can see the red arcs. You see the red arcs? 10 microns change in 4 months. You can make out these changes very easily. You can, of course, look at the average values and start counting those numbers. This is an example of high-risk progression. You can see where there is a change. It is in the superotemporal region. Any loss of tissue in the superotemporal region is critical for vision because it means that the patient will develop an inferior paracentral defect. And that is important for reading. So therefore, any superotemporal loss is a critical loss. And you can see that here on the macular thickness. Now, sometimes these machines can fool you. So you can see there is a negative slope. Tissue thickness is getting lower and lower. You can see that in the nerve fiber layer. Not real progression. It is actually posterior vitreous separation, posterior vitreous detachment. The vitreous has pulled away and therefore the fiber layer has become thinner. So it looks like progression, but it's not. And therefore, there is no change on the macular thickness. So what I want to show you is that if it is real glaucoma, the change has to be first in macular thickness, always. And then you may pick it up on the nerve fiber layer thickness. But if you pick it up on the nerve fiber layer thickness and it's not there in the macula, that change is not real. Masking of progression. These epiretinal membranes have a dirty habit of sitting around the optic nerve. We never paid attention to it because it didn't have visual acuity, but it affects OCT. So when the thinning happens underneath this epiretinal membrane, the measurement stays stable, though the actual thinning is happening. And this is how I have learned to cure glaucoma in my spare time. You see this? No nerve fiber layer. 2 years later, full of nerve fiber layer. How is this possible? This is uveitis. Uveitis causes swelling of the nerve fiber layer. We discovered this by accident, and the accident was this page. You can see how the nerve fiber layer looked normal, cup looked small. We did glaucoma surgery, and despite the glaucoma surgery, the nerve fiber layer kept thinning despite very good pressure control. When we realized that the treatment after the glaucoma surgery was the steroid was curing or treating the uveitis that was underlying. This patient never had this amount of nerve fiber layer thickness. It was false. It was all swelling. That swelling came down to normal, or to baseline, I should say, not normal. No wonder the field didn't change. Some silly examples that are there in the OCT, and that is here. The patient comes with no nerve fiber layer. Whenever nerve fiber layer drops to 0, it is an artifact. Minutes later, full nerve fiber layer. Why? Because the technician did not know that they have to bring this thing into the middle of the window. They cut it off here. So you can get silly false results. And then sometimes the machine makes mistakes. So you can see progression here, but that's not real progression. That's because of segmentation artifact. And I'll end with just this case. This is a patient I saw who looked like having glaucoma progression. Okay, you can, oh, last slide, come on. You see this loss of nerve fiber layer here. You see macular thickness loss. You see new field loss, right? So as they say, if it is talking like a duck, walking like a duck, it's a duck, but it's not a duck. This is not glaucoma. Looks exactly like glaucoma, right? But it was actually a cotton wool spot that I found from old images of this patient from few months ago. And I thought it was a optical artifact. When I zoomed in, I was able to identify that it's a cotton wool spot. So then I realized that cotton wool spots are happening unknown to us, multiple places all over the fundus. We barely get to see them, but they are resulting in these arcuate losses that look exactly like glaucoma. So this is something that I'm finding out only recently. So again, we have to be very careful. So decrease of the global nerve fiber layer is not specific to glaucoma, can occur in non-glaucoma conditions. Posterior vitreous separation is the biggest mischief maker. Artifacts are present in 1/3 of the scans. Examine symmetry or lack thereof, and not all progressive nerve fiber layer thinning is due to glaucoma. Thank you. Yes, your machine can give you fake news.
Thank you very much, Dr. Sanjay, for this very clear pearls on OCT. Now we can start our next session on the trabeculectomy innovation in blade-forming surgery. And we will start with Dr. Tina Wong, this eminent glaucoma surgeon, trabeculectomy versus for your patient, how to choose.
Thank you very much for the introduction. Okay, so part two. Here we are. Okay. I'm going to talk about the PreserFlow, which I believe is coming to you very soon in Egypt. And I thought I would just put this presentation together so that perhaps you have some ideas on when and how you may want to consider using the PreserFlow for your patients. I have no financial disclosures for this implant. Okay, so we were just talking at lunchtime, and we're saying that, you know, options were very simple back in the 80s. I mean, I was still at school, but when I was training as a medical student and ophthalmologist, there was only really one operation, which was the trabeculectomy, to be honest. Okay, and then at the time we were taught, you don't do the trab until, you know, you've got very bad glaucoma. Then you tell the patient they've got to go for this big eye operation. And then if that fails, you may want to do a tube, and then that's game over. It's the end of the road, really, back in the day. But now, surgical options today, wow, we've got a huge platter. We've got a buffet from phacos, MIGs, MIBs, trabs, and tube. But what I'm talking about is the middle child, okay? I don't know how many children you all have. I only have one, but sometimes the middle child has an inferiority complex, gets neglected. We don't really know where it fits in the whole treatment paradigm when we're talking about surgical procedures. And so really today's lecture, this next 10 minutes, I'm just going to share with you some experiences myself and my colleagues in Singapore feel where the middle child belongs in terms of your surgical management decisions and when to present this as an option to your patients. So what does the ideal bleb-forming surgery look like? Well, I think it has to last at least 10 years. It has to be agnostic to any type of glaucoma that you encounter. It's got to be effective to manage in terms of how to modulate the scarring response. And what I'm talking about are like bleb needlings and rescuing a failing bleb. And therefore, you can have a favorable bleb morphology, which will then be comfortable for the patient and not cause complications. So if we talk about the first two, if we think about the PreserFlow and trabeculectomy, which one do you think we should consider for this patient? Well, you might say, well, both. You know, it doesn't matter. It depends on which one I'm good at. This was done for a patient in 2009. We didn't have the PreserFlow back in the day, and this patient had a trabeculectomy, and 11, 12 years later, it still looks pretty much the same. So we know that trabs work, okay? This is a photo of a patient of mine, 13, well, coming to 14-year anniversary of his phacotrabs that I performed as a junior consultant. His pressures are amazing. I mean, this is something that's textbook I'm very proud of, but they don't look like this, right? But we did a very large series in SNEC, and we had about over 450 patients who went for combined phacotrabeculectomy. We followed these patients up for over 10 years. There was a mixed bag of different types of glaucomas, but it was a real-world audit on our surgical outcomes of 10 consultants in the glaucoma service. And what you can clearly see is that, you know, it does work. You have good success, overall success of about 80 to 90%. We counsel and consent patients that trabeculectomy is good, and we can see that the post-op dependency on eye drops on their last visit is obviously significantly reduced. However, a caveat is that in Asia, we do see about 30% that require BEB needlings and post-op interventions because of the scarring response. So we're now talking about PreserFlow, new kid on the block. Are we actually really going to see a 10-year PreserFlow looking like this? I'm not sure because it's not been around for long enough. So what I want to show you here is what the PreserFlow looks like. It's a device which is a minimally invasive blood-forming implant, ab external implantation, which is unlike the Zen, which is ab internal. The thing about it is that you don't need to create a scleral flap, meaning the learning curve will be much easier if you already know how to do a trabeculectomy. You do need to use intraoperative mitomycin C, and then basically you implant the device. If I just quickly fast forward, so you tunnel with an MVR blade, which is marked, and you introduce it to a certain point until the clear parts, the shiny part has disappeared. And then after that, you will then advance your knee, create a tunnel for tubes. Then this is the PreserFlow implant, and these little fins. And those fins are the anchoring fins. So what you do is you advance the PreserFlow all the way down, but close up. You need to flick it a little bit. The reps will teach you some tips and tricks on how to get the flow going, and therefore you then just close up. Okay, so it's quite simple, and it's a lot easier and faster than a trabeculectomy. So what is the data? What is the evidence? What I can share with you here is that this was a big series, randomized controlled trial over about 30 sites across the US and Europe. And it was prospective. These senior surgeons, about 6 of them, were randomized to either do PreserFlow or a trabeculectomy. And they used mitomycin C, which was same concentration for both treatment groups. What we found really was that the success probability of success at 1 year. Medication burden as well was not looking in very good shape. If you look at the bar on the far right-hand side, you can see that the number of medications at 1 year after surgery was beginning to creep up with the PreserFlow group. The other thing is that, you know, if you've got a blood-forming surgery, you need to rescue it. And we're all very familiar about doing blood-forming surgeries and then doing needlings. So this is a patient that I actually rescued. And he was, when I saw him, he was on 3 medications, had a trabeculectomy about 15 years, and had been medicated to keep his pressure under control until he came into the clinic. I said, look, you know, sir, I think I can try and give you, rescue this surgery. Checked, and the ostium was still open, and he looked at me and said, well, how are you going to do that? You're a magician, because no one ever told him that he could have this done. The problem with PreserFlow is that rescuing failing PreserFlows is not so easy, because the needling technique is different. You don't have a flap to lift, all right? You saw that there was an implant. The learning curve is tremendous, even at the best of hands. There are too many variables as well. Scarring tissue, the PreserFlow can come out and you can dislodge the hole. And then what you have to do, patient in and open it. And you can. So I think, you know, discussions and we've had the PreserFlow for years now. And really what I want to do is to share some pearls as well for you about. I think for sclera, namely the ones that are high myopes, where, you know, fashioning a scleral flap may angle closure, well, you can't do it in fake eyes, obviously, it's contraindicated. So if you're going to do a very high risk of failure because angle closure. So I just actually made it very simple in traffic light. So surgical technique is mectomy, but if you do it right, you can get the you want. For PreserFlow, it's a much lower learning curve, so it's easy to do and so forth. The main thing is about how to modulate the scarring response, and that's a major thing that weighs the difference between trabeculectomy and PreserFlow. So here are just some considerations when you're selecting your blood-forming surgeries for patients with TRAB. I would say that it has to have a moderate visual maximum medical therapy as usual. Maybe they're on Diamox. Angle closure, you can do standalone or combined. And you normally for trabeculectomies want to achieve much lower IOPs, such as oh, there we go. Thank you. So they don't want me to talk about the PreserFlow. Okay, so the PreserFlow, I would say the best fit for this middle child is someone that is on a 3 or 4 medications, have no or very mild visual field loss, that does not fit into a MIGS group, because obviously if you're going to do a MIGS on a patient on 4 or 5 medications, they're still going to be on 1 or 2 medications after you do your MIGS. And so this is the group that I think would fit just nice for PreserFlow. Obviously thin sclera. Target IOP doesn't have to be super aggressive, so you can aim for the mid to low teens, is okay. And if the patients are unable to return for frequent visits, this would be a very nice fit for offering PreserFlow. So with that, thank you very much. I know you've seen this morning, but I'd like to remind you again this afternoon because I'm very persistent. Please send abstracts in, and we would love to see you in Singapore. Thank you very much for your attention.
Thank you very much. Just one question, please. What is the ideal patient profile in short sentence for PreserFlow? Ideal patient profile.
Ideal patient profile. Somebody with little glaucoma, but on a lot of eye drops. 2 things. Not much glaucoma and a lot of eye drops, which don't fulfill either just doing a phaco or doing a fake mix. You know, because the thing is that if somebody, we were having this discussion, Ahmed, weren't we? If you have a patient on, say, 4 medications like Gamfox, Cybrilza, and Rapazidil, like a ROCK inhibitor, that's 5 medications, and yet they don't really have much visual field loss. They might have an MD of -3. It doesn't justify trabeculectomy. Then if you do a MIGS or even a GAT, you might not be able to achieve the pressure lowering adequately. And so I think PreserFlow then fits this sweet spot. I'm trying to find something for the middle child here, but I think I have almost cracked it. So I think that's where I'm going with it. And also, PreserFlow is good for patients who are high myopes, or if you've got thin sclera, where you feel that you're not comfortable doing a scleral flap.
Thank you very much.
Thank you.
Thank you.
Extrusion is very little because of the device is very small. One of the tips which I didn't show you was that when you put the shunt in, you may use a 10-0 nylon to tie it down, because often it flips up a bit and it tents your T-knots and it then causes a bit of scarring. So one of the tips you can do when you start learning it, you'll find that when you put the PreserFlow in, it doesn't sit flush on the sclera and it comes up a little bit. So to push it down, then the flow goes posterior. You're not tenting up your condyles, stimulating T-nodes and fibrosis. So that's one of the tips as well. Okay. Thank you, Dr. Tina. For the next talk, Dr. Barak will be presenting to trabeculectomy.
Good afternoon. First, I want to thank the organizing committee for your kind invitation. It's an honor. Dear colleague, I will talk today about the tubal trabeculectomy. First of all, how does TRAB reduce the intraocular pressure? First, you solve these obstacles to get the reduction in the intraocular pressure, smooth passage of the aqueous from the anterior chamber to the vascular flap. Second, you must avoid to decrease the flap fibrosis. Ensure steady, consistent passage of the aqueous from the underscleral flap to the subconjunctival space. Lastly, to abrupt or more or less to slow down the subconjunctival fibrosis to facilitate the aqueous absorption. I will talk today about this part only. We'll start with how to ensure the steady, consistent passage, starting with the curved scleral flap, then with the deep extended scleral tunnel, and the X-shaped non-absorbent subflap suture, and lastly, the tube implantation, which extends from the underscleral flap to the subconjunctival space and buried in the scleral tunnel. And of course, the sutures in the last. The traditional scleral rectangular flap with the sharp edges may simulate the body cells to be aggressive in the healing process. And then we shifted to the curved scleral flap, and they may be more friendly in the healing process. And here is the curved scleral flap. Then we go to the deep scleral tunnel. This technique enables the aqueous to reach the tunnel in the deep sclera and move through it smoothly and easily with a minimal resistance to achieve the subconjunctival space. And this tunnel must extend beyond the scleral flap. If you have to put a scleral resonant tube, you can go to the very short extended scleral tunnel. Then how to maintain the subscleral flap space. In the past, we used the horizontal subscleral flap version, non-absorbable version silk suture. But nowadays, I shifted to the X-shaped subscleral flap 8.0 non-absorbable silk suture. And it has more advantage. First, to preserve the subscleral flap space and to keep this connection open between the subscleral and subconjunctival and to secure the tube in its position. And here we can see how we make the X80 version silk suture. Then we go to tube intubation and implantation, which extends from the underscleral flap to the subconjunctival space buried in the scleral tunnel. I'm shifted now to the nasolacrimal tube. Previously, I'm using the, it's a gauge 26. Now we go to the nasolacrimal tube. استاذنكم لو سمحتوا الصوت عالي قوي ومش قادر اركز يا استاذ لو سمحت. We go to the material medical grade silicon, then to the because it's biocompatible, inert non-reactive, flexible, smooth surface, resistant to degradation and colonization, and lastly, it's a autoclavable. And here are the diameters and dimensions of the nasolacrimal tube. And lastly, it costs only $1 for every operation. And here we insert the nasolacrimal tube under the X-shaped non-absorbable suture. Then, of course, we do the normal trabeculectomy after insertion of the tube and peripheral atherectomy as normal. And at last, we secure the ends of this tube by a 10-0 to get rid of the elevation of the distal part of the tube. And here is the picture after making the sutures of the flap. And of course, it's a physical barrier and not for the passage of the aqueous through this tube. Lastly, the conjunctival tenoscleral suture is a must. I think tendinectomy must be abandoned because if you cut the tenon, it will recede back, and I think it's a problem in the fibrosis in the posterior part. You can put the suture in this fashion or do the purse string suture, which is 3 sutures, taking the tenon and the conjunctiva 3 times, and the same in the other side, and you will get a very secured closure of the tenon with the conjunctiva and sclera. And you can test this closure by just inflation of the anterior chamber with saline, and you will see that the ballooning of the conjunctiva is very obvious. This blip should not be seen with the ischemic part and the ugly blips, and we are aiming to this kind of blips by this technique. Lastly, glaucoma is a monster. If you fail to kill from the first shot, it will be very aggressive and difficult to control. I think this is the golden principle of glaucoma surgery in my mind. Thank you very much.
Thank you very much, Dr. Tara. Next presentation will be Dr. Tara Eid, complication of glaucoma surgery, how to avoid.
Thank you, Mr. Chairman. Actually, I'm talking about complications of glaucoma surgery after 2 wonderful lectures of Wonga and Dr. I may take the downside of glaucoma surgery, which is the complications and how to avoid. Definition of a surgical complication in general is any undesirable, unintended, and direct result of an operation affecting the patient. And this can be avoidable or unavoidable, negligent or non-negligent, and it may be surgical effect or the effect of the underlying disease or the condition of the patient. Decision of surgical treatment of glaucoma depends on many factors: the patient's own sense of visual function, amount of loss in nerve, rate of progression, magnitude of the pressure elevation, general health, life expectancy, response to other treatment modalities, especially medications and laser, and the status of the contralateral eye. What are the benefits and risks of surgical intervention? Why you do glaucoma surgery? Why you do surgery in general? Benefits for the patient: the hope to permanently reduce eye pressure and delay or stop glaucoma progression and minimize cost and side effects of medications. But on the contrary, the risks include exposing the eye and the patient to surgery and anesthesia risks, also spending much more stress and money and time of the patient and the surroundings during and after the operation. Regarding the physician or the surgeon, the benefits are utilization of extra tools of management, satisfaction, developing more surgical costs and surgical skills, and certainly gaining more money. But the risks for the physician include extra effort in dealing with post-op course and incident complications, facing consequences when results are less than expected, and again facing medical legal issues. Glaucoma operations actually can be classified into 2 major categories, which are internal. We usually call them mixed. It can be incisional, like goniotomy, GAD, omni, excisional, like hook, bang, or or implant supported, like iStent, soft, hydrous, and CPAS. Or maybe external, which are the conventional procedures, like penetrating, like the trap, non-penetrating, like vesicocanalostomy, sclerectomy, and canaloplasty, or maybe implant supported, and the implant can be either equatorial implants like the traditional Martino, Ahmed, Pervert, Clear Path, and Paul, or maybe the perilimban as Express, Reserve Flow, Microshunt, and Zengel. The incidence of complications of glaucoma surgery is actually high, up to 50%. In the CIGET study in USA and also in the National Survey in UK was 46%. The TVT study reported 57% of complications after PrEP and 37% after tube. The risk factors of complications of glaucoma surgery include the surgery itself, the disease, the surgery, the patient, the eye, the body, medications, anesthesia, operating room, and other stuff. Let's talk about the surgery itself. The glaucoma surgery, certain types of glaucoma surgery have high risk of complications, such as full thickness operations, trap, or tube. Prolonged operation time will get more risk for complications, emergency operations, or combination of multiple surgeries together. The disease, which is a glaucoma, advanced stages with successive splittings carry high risk of complications, disturbed anatomy like secondary glaucomas after ocular surgery or congenital anomalies, preoperative risks, persistently elevated IOP or neglected acute attacks. The surgeon, incompetent, inexperienced surgeon, lack of patience, focusing, and accountability. The patient himself, very young and very old, are high-risk patients for surgery. Males carry high risk than females, anxious, non-competent, and intolerant patients. The eye, associated with high mobility in the eye. The body, patients with poor healing power, septic foci, high mobility and mortality, some systemic diseases affecting post-operative course, like diabetes, obesity, renal failure. Medications, prolonged glaucoma medications affect the conjunctiva and cornea. High risk medications, if not discontinued, like pilocarpine, systemic carbonic anhydrase, anticoagulants. Steroid therapy may decrease healing power. The anesthesia, the risk of anesthesia on the patient and proper choice of the anesthesia technique for the surgery. And the OR itself, if lack of standardization, poor equipment, and poor sterilization technique. The OR staff, poor training, lack of experience, harmony, and operations. So all these are risk factors which increase the likelihood of surgical complications. The list of possible operative and post-operative complications can be grouped into these 10 items, either injury of a tissue, bleeding, infection, scarring, pressure turbulence, visual loss, structural changes, cosmetic effects, systemic effects, or even psychic problems. These are some examples of complications that can happen with hyphema, lost AC, psychodialysis, cleft, malignant glaucoma, choroidal effusions, expulsive hemorrhage, or maybe dehiscence of the bleb, high bleb, encroaching on the cornea, leaking bleb, endophthalmitis, hypotony of the blocked tube, insisted bleb around the blade, tube exposure, tube cornea touch, even implant extrusion and disfigurement. So all these are just some, not all, complications can happen from the glaucoma surgery. The question is, how can we avoid? The first thing in the management strategies of surgical complications in general is the root cause analysis. First, identify the effect, which is a complication, then identify the main causes directly resulting in this effect, and identify the factors, the risk factors that contribute to the main causes. Actually, for prevention of such complications, communication with the surgical team is very important. A surgical checklist helps to avoid oversights and reduce distraction. This is just a surgical checklist provided by the World Health Organization's checklist before giving the anesthesia, and then before starting the operation, and then before the patient leaves the OR. Reporting system is very important for the operative notes and also unintended events and then we have to address and treat all risk factors. Recommendations specific for glaucoma surgery: before the surgery, stop anticoagulants and antibiotics, prophylactic antibiotics, treat any source of infection, treat intraocular inflammations, reduce intraocular pressure, proper patient counseling. During the surgery, proper selection of the anesthesia, meticulous handling of the tissues, avoid prolonged loss of anterior chamber by viscoelastic or AC maintainer, avoid hypotony by pre-placed flap sutures, cycloplegics at the end of the operation, especially for angle closure glaucoma, primary hyaluronic if there is high risk of malignant glaucoma, prophylactic sclerostomy if there is high risk of supraglottic hemorrhage. After surgery, think about very close follow-up and assurance of the patient, minimize anxiety, mental stress, physical activity, training. Cycloplegics are very important and very useful in the early post-operative days. Head-up position if there is edema. Keep an eye on general condition of the patient with proper control of systemic illnesses. Measures to manage overfiltration like large bandage contact lens, pressure patch, or significant ring. Early detection and treatment of conjunctival lesion, and measures to manage high intraocular pressure like massage, laser suture lysis, releasable sutures, needling, flap lift, and head drops. And one last thing is concerning the medical legal issues and the glaucoma surgical complications. Actually, if your patient as a surgeon is the main safety, think of doing nothing for the patient. But if your patient's safety is the main issue, do nothing unnecessary. Thank you.
Thank you very much, Dr. will be a title of a congress rather than a presentation. Really. Thank you for this concise presentation. ايه رايك حضرتك يا دكتور عادل الكومبليكيشن اوف جلوكوما في ضوء القانون الجديد يكون Next presentation will be the Syed Mohammed Saeed. Trabeculectomy with opening of suprachoroidal space.
السلام عليكم جميعا. Good evening to all. With the opening of suprachoroidal space, I am from Tanta University, Dr. Tariq Eid, Dr. Tariq Abdullahi, Dr. Muhammad Al-Hamid, who are presenting all over today. Trabeculectomy is the standard of glaucoma operations. أحب وكره من كره. الدكتور ابو النصر في المؤتمر بيمتعنا بالموديفيكيشنز في الترابيكليكتومي. فاugmented trabeculectomy was tried with anti-methacrolide, amniotic membrane transplantation, anti-VEGF, and urology, but with some complications as hypotonicalopathy and delayed bites and endophthalmitis. We do an MDCs at Tanta University, and we find that anti-metabolite mitomycin is the best, followed by amniotic membrane or origin, and lastly by anti-VEGF. Microincision glaucoma surgery techniques are mainly in microincision glaucoma, so sometimes are now done for advanced glaucoma, but there is no long history for these operations to follow up till now. Makes the main advantage is in the combined glaucoma surgery, so some MIGs are used standalone for glaucoma today. Attempts to use the suprachoroidal space for outward drainage date back nearby 100 years ago. The operation named cyclodialysis operation. We do this operation while we are in the residency at 1980s. Of late, there has been a renewed interest and more attention in using suprachoroidal space by application of topical drugs and implants as bypass macro stent, although it is withdrawn because it causes endothelial decompensation after 5 years follow-up, and iStent supra, which is still present from glucose. Also, suprachoroidal tube drainage with desclerectomy was tried, as Dr. Hazen said today. Combining thoracectomy to drain aqueous into Schlemm's canal and subconjunctival space with a cyclodialysis cleft to create a controlled entry into the suprachoroidal space will increase the success of thoracectomy. Injection of heavy heron or heron 5 into the suprachoroidal cleft, aiming at maintaining the drainage, decrease the fibrosis, decrease late closure, and also into the anterior chamber to guard against hyphema, and post-operative shallow anterior chamber is a new idea. This is the operation. Conjunctival suture, traction suture by 700 victory. Injection of subconjunctival sign, especially in recurrent cases, and then doing the fornix-based conjunctival flap. Then diathermy of the episcleral blood vessels, as usual, trap as usual. Then measuring the external flap, 3 by 4 millimeter. Then landmark with the external flap by Barker knife 15. The section of the sclera to separate the external flaps from the inner sclera by crescent knife. Crescent knife will end in a smooth plane between the external and the inner sclera. The section of the flap till the corneoscleral junction is appeared. Paracentesis is a must in all glaucoma operations. Then the section of cutting the inner flap. Now we inject the heavy hero, volume 5, into this cleft and to reduce it inside this sclera. Doing the peripheral suturing of the external flap. This operation avoids the complications of micromycin C or the expense of collagen. Can be called viscotrabeculectomy. This levihelon is injected under the external flap and also in the anterior chamber to guard against shallow anterior chamber and post-operative hypotomy. Then closing the pouch and this in variation. Thank you very much.
Next talk, combined phacotrabeculectomy, special consideration, Professor Dr. Ahmed Bishar.
بسم الله الرحمن الرحيم.
احمد بيه شغل اصر ان هو اللي يقدمك يعني من ساعه ما قعد يعني اهلا وسهلا.
احمد اخويا واستاذ معيد جامعه المنيا ووكيل الكليه للدراسات العليا والناس اللي هم ليهم يد بيضاء على من ساعه ما انشأ.
بسم الله الرحمن الرحيم. I will some special concerns in the combined phacotrabeculectomy. Glaucoma and cataract are common comorbidities. The management of glaucoma could be complicated by the presence of cataract. Moreover, the presence of the crystallis itself may become an integral factor in the pathogenesis of glaucoma. Surgical treatment options include glaucoma surgery alone, cataract surgery alone, subsequent glaucoma and cataract surgeries, or vice versa, combined cataract and glaucoma surgery. When we do glaucoma first, we may have the rapid progression of cataract, difficult phaco surgery due to shallow see hard cataract and posterior synechiae, impaired function on subsequent phaco surgery, and fallacies in biometry, especially with contact technique due to underestimation of the axial length with bionic shift. When we do phaco emulsification first, any post-operative spikes of the intraocular pressure may occur due to post-operative inflammation still, and this is of special concern in cases with advanced cupping with inferior results of subsequent glaucoma surgery. We can consider cataract surgery alone in cases of primary angle closure and primary angle closure glaucoma as cataract removal will address the two conditions and prevention. Also, in open angle glaucoma with mild glaucoma, and residual fusions in primary open angle glaucoma, and they get better outcomes and less complications with phacoemulsification alone compared with phacotrap. Phacoconiocyanolysis was first described in conjunction with cataract surgery in 1984. Typically, it is indicated in cases with posterior synechiae, but also with synechiae, peripheral synechiae affecting more than 50% of the eye. Combined cataract and glaucoma surgery. Back into the history, in 1987, combined trabeculectomy with extracapsular cataract extraction reported 3.6 millimeter reduction of the mean intraocular pressure. Later on, Kubro et al. In 1999 compared combined trabeculectomy with extracapsular cataract extraction versus cataract surgery alone and report a reduction of 8 millimeter mercury versus 4 reduction respectively. When we do combined cataract and glaucoma surgery, potential advantages include a single visit to the operating room with reduced cost, risk of anesthesia and stress. Also, it avoids post-operative IV spikes after cataract surgery, especially in cases with advanced optic neuropathy. On the other hand, potential disadvantages include more intraoperative and post-operative complications, more inflammation than either glaucoma or cataract surgery alone. Also, combined procedure may be less effective than glaucoma surgery alone in control of the intraocular pressure. There is a long list of operations surgeries that can be combined with cataract surgery. Many mixed technique, trabeculectomy, non-penetrating deep sclerectomy, express mediation, glaucoma drainage device, GAT, dual bleed, and external canaloplasty, canalostomy, ultrasound cilioplasty, endoscopic cycle photocoagulation. I talk about combined trabeculectomy. There are special considerations. The overall considerations include proper control of the intraocular pressure before surgery. There's some debate about what medications can be used for this issue. Anyhow, if the intraocular pressure is very hard, consider two-stage procedure as cataract extraction lead, post-cataract extraction lead, as the risk of suprachoroidal more with prolonged combined surgeries incidence. The use of mannitol is not contraindicated, may be very helpful to both control the intraocular pressure and to use positive pressure with, of course, to proper pupillary dilatation. Anesthesia. Topical anesthesia is frequently used in cataract surgery. However, it doesn't provide anesthesia. With inadequate sensory blood for the iris and ciliary blood is relevant for patients with glaucoma with shallow AC, small pupil, or suicide. Also, combined cataract surgery tend to be intensive surgery and better to perform using bilateral or subtenal anesthesia, with some concerns and some debates on the effect of the local anesthesia on the particular function in advanced glaucoma. Single site versus two site surgeries. This topic will be addressed by my dear colleague Professor Ahmed Mustafa. In brief, the advantage of single site surgery is to save time when no need for to change the position of the surgeon or the microscope. On the other hand, the advantage of the two-site surgery is improved exposure to BBCI and palpebral fissure, less inflammation, less conjunctival manipulation with enhanced lip survival. Anti-whites, a previous study reported no benefit from the use of 5-fluorouracil and small benefit for the use of mitomycin C in combined phagotrap. Other study with combined procedure indicated the use of mitomycin C provide more stable visual field, less use and lower intraocular pressure. The size of the rexes is very important. Large rexes may allow possible acute displacement of the IOL if the AC function postoperatively. On the other hand, small rexes lead to complicated surgery and possibly capsular phimosis. IOL should use hydrophobic IOL because it maintains its position with less postoperative inflammation. The outcome. Almira et al. Compared combined phagotrap versus phago followed by trabeculectomy, they had no significant difference in cumulative probability of success in primary open-angle glaucoma, except for the exfoliative and uveitic glaucoma. Our guest speaker, Professor Dina Wong, and her colleague last year published a study in the long-term outcomes of phagotrabeculectomy in about 800 eyes, with follow-up for at least 3 years and up to 13 years. They had 90% of cases had intraocular pressure below 21, 92 below 18, and 66 below 15. However, these results could be affected by inclusion of both types of glaucoma, angle closure and open angle glaucoma. Other surgical options include phagocanaloplasty in comparison between phagocanaloplasty and combined phagotrap. Phagotrabeculectomy achieved a sensitivity rate of median percentage decrease in intraocular pressure, as the two procedures by the end of follow-up period by about 1 year are comparable results. In a study in the UK 10 years about the use of phagotrabeculectomy, it looks like from the first spot the results are very good with cumulative qualified success without the use of post-operative medications is about 19 millimeter. However, if we look carefully for the results, we will find that if we need the intraocular pressure less than 16 millimeter, about 30% from the baseline, we will get the success rate without medications about 55% only. Express medication can be surgical with considerable more cost. Glaucoma drainage device will help reserve for the complicated secondary glaucoma. Phagoemulsification with IOL implantation may be done first, then doing the shunt. Other surgeons prefer to work on a firm eye, so fix the blade first and then introduce the tube and then PC after fixing. Get can be combined with cataract surgery with growing bronze implants. The whole blade can be used also in conjunction. Cataract surgery is not really available in Egypt and somewhat expensive. FICO ultrasound plus in the study compared FICO AUCD with FICO alone. There is a median reduction of 7 millimeter compared to millimeter respectively. Take home message: combine FICO glaucoma surgery in treating patients with visually significant cataract and open angle glaucoma mainly, uncontrolled with local indications. There are many combined options. And FICO clear is a positive surgery, however, as with other combined procedure, patients need to use post-operative eye drops. Thank you.
Thank you. For the next group, Dr. Muhammad Al-Mahdi present hypotony after glaucoma filtering surgery.
Thank you very much for giving me the chance to present again about hypotony after glaucoma filtering surgery. Before proceeding, we have to define first what is the hypotony. Hypotony is a common but potentially vision-threatening complications might happen after glaucoma filtering surgery and is defined as intraocular pressure that is 3 standard deviation below the normal, and means less than 6.5 millimeter mercury, and intraocular pressure low enough to cause visual impairment, even if it is more than 6. It manifests in the form of hypotony, maculopathy, corneal edema, astigmatism because of the low tension, choroidal effusion, and accelerated cataract formation. Treatment is typically reserved for a patient with visual impairment and is often not for those with asymptomatic or statistical hypotony. As long as there is no visual impairment, usually there is no need for interference. Successful filtering of bleb characteristic, we should know that it's elevated, diffuse, wide, and microcystic. And failing the bleb is classified as this one with high intraocular pressure, which is not the now, but we are talking about the bleb with low intraocular pressure, either due to leakage or elevated bleb due to overfiltration. And the cause of hypotony is 2 main categories: those with decreased aqueous production and the other with decreased aqueous outflow. Aqueous production could be decreased due to inflammation or cellular attachment, or the most common cause that could happen that inadvertent use of aqueous suppressants that the patient is continuously using while you are doing the surgery, and even after surgery, you have to ask the patient to stop all the current anti-glaucoma medication, even systemic or topical. Ciliary shutdown as well. Increased aqueous outflow due to excessive filtration, usually with full thickness, and use of antimetabolite, especially if the concentration is not well calculated, bleed, lose flature, cyclodesk, left and choroidal detachment. The clinical finding bleb assessment, we have to assess anterior chamber depth and to grade the anterior chamber into grade 1 with only peripheral iris, shallow anterior chamber in the periphery, while it's preserved in the center, and grade 2 and grade 3 with complete touch. And we have to assess the bleb height and to check for conjunctival buttonholing and leakage, and to see if there's positive seed test or not positive, and to see the fundus for the presence of choroidal detachment and detection of hypotony maculopathy if it happens. And also you could do some sort of OCT or ultrasound for the eye. Bleb examination flow chart includes intraocular pressure assessment, anterior chamber depth, whether flat or deep. If it is flat, either positive sided or negative. Positive sided usually due to conjunctival buttonholing. Deep anterior chamber with high bleb usually due to overfiltration and hypotony maculopathy. The management of overfiltration usually either observation or immediate intervention. Observation is indicated for overfiltration with formed anterior chamber with elevated bleb. Means that anterior chamber grade 1 with restriction of activity like bed rest, avoidance of weightlifting, constipation, and sneezing, and this kind of vigorous movement. Immediate intervention is only indicated in grade 3, corneal touch by external temperature. Usually is not successful in these cases. We have not to resort and immediate reformation of the anterior chamber either hair or BSS is elastic and SF6 might be indicated. Sclerotomy with drainage of suprachoroidal effusion or suprachoroidal hemorrhage might be necessary in these cases. Otherwise, for grade 2 anterior chamber we could use bandage contact lens. The use of the available contact lens was only about 14 millimeters is not enough to cover the bleb here. We have to use the proper bandage contact lens at 17 to 20 millimeter, and we can use it for 5 days. We use Simon shell, use cryo application, or use argo laser, or autologous blood injection, or compression suture. Here you can see we can inject the patient on autologous blood injected directly into the bleb away from the scleral flap in order not to allow for the blood to enter the eye and lead to hyphema. And then we can also do compression suture by anchoring the suture to the clear cornea and posteriorly to the sclera behind the flap and compressing the flap and the conjunctiva as well in these cases. And also, choroidal effusion, if we see it like what we can see here and do ultrasound, usually conservative treatment is indicated, target towards a specific etiology of the hypotonia if we know it. This approach includes treatments such as cycloplegics and steroids, but surgical drainage is only indicated for persistent or large infusion, which is usually accompanied by symptomatic vision loss or flat anterior chamber. Here, cyclodels cleft, the pathophysiology cyclodels cleft could occur where the ciliary body is detached from the scleral spur, creating an abnormal pathway between the anterior chamber and suprachoroidal space. It usually occurs iatrogenically with any intraocular surgery that involves manipulation of the anterior chamber and angle structure, specifically with minimally invasive glaucoma surgeries like goniotomy, dual blade, and GAD, and this kind of. It's very less common with, but it happens mostly with manipulating this area during the minimally-invasive glaucoma surgery. Management of cyclodels cleft includes cycloplegics or argo laser transcameral cyclophotocoagulation or cryotherapy, which could be repeated as deemed necessary, provided that the vision is not that much affected. And usually it is reserved for small cleft less than 3 clock hours, but for large cleft between 3 and 6 clock hours, direct cyclopexy is indicated, where we can do complete scleral flap, exposing the ciliary body, the metal suture, and boring the ciliary body to the back of the sclera. And I think the tutorial will present something like this tomorrow. Delayed postoperative hypotony maculopathy. This is a case I have met and I will present now. 8 months postoperatively, I have met a patient with delayed postoperative hypotony. The patient is a vitiligo patient. During her follow-up, bleb was noted. Intraocular pressure was 6 millimeter mercury. Blip exam revealed high diffuse blip. OCT was done at visual field as well. The photograph available was this one. I did this OCT for see the macula, and I treated this patient with repeat compression suture that has been displayed just right now, and then I did repeated autologous blood injection into the subconjunctival space overlying the bleb. I did it at the time of scleral fixation sutures. Then I repeated alone after this one and left the scleral fixation sutures for more than 2-3 months till the case is completely cured. And here is the OCT after 2 or 3 months. And this is the visual field of this eye. And the patient is seeing 6-12. And of course, no one can understand and believes that this patient will improve. Patient with hypothalamic maculopathy should be treated, and we should lose hope in treating this patient all the time. Thank you very much.
Thank you very much. The next presentation will be with Chief of the Glaucoma Society, Dr. Adel Abdelaziz, modification, wound healing, and trabeculectomy.
كبرزنتيشن بشكر حضراتكم جميعا، يوم طويل ومتعب، واشكر حضراتكم على وجود الحضور لاخر المؤتمر.
بنشكر حضرتك والله يا دكتور عادل على المجهود الجبار، ويعني ادينا من المؤتمر. اتفضل اتفضل يا فندم.
The main determinant of IUP after the competition surgery is the healing response. Although the anti-retrovirals have recognized glaucoma surgery, the use of this agent is still associated with complications and failure. Therefore, there is a need for better agents to improve their risk-benefit ratio. Wound healing involves the case and overlapping phases of inflammation, granulation, and hemorrhage. Stage wound healing is stage 1 acute inflammatory response, in which the fiber and clot is formed and neutrophils draining veins. Stage 2 fiber loss and reduced tissue formation, including formation of new blood vessels. Stage 3 wound remodeling, the matrix metabolism remodeling the fibers and collagen components of the retinal scar, which is characterized by turning over the collagen in which the new type 1 collagen is formed, degraded type 3 collagen, which increases the tensile strength of the wound. Overlap phase of wound. There is overlapping in relation to the time wound phase intensities. The problem with wound healing glaucoma, the conjunctival tissue injury leading to fibroblasts proliferations and the new blood vessels formations, granulation tissue, and the tissue remodeling, which includes fibrosis and complete resolution, or leading to scar formation. We can abolish this or remodel by anti-VEGF, anti-tissue factors, and so on. The loss and success rate of glaucoma surgeries are largely dependent on wound healing and adhesions. Exaggerated wound healing always results in closure of the passage between AC and subconjunctival space. Tenon fibroblasts are the main effector cells involved in initiation and of wound healing. Tenon fibroblasts and myofibroblasts and tissue response. Methods of wound modulation, either traditional methods or new methods. Traditional, the anti-inflammatory agent is steroids and non-steroidal anti-inflammatory drugs and anti-fibrotic agents, mitomycin C and 5-fluorouracil. The new methods, anti-VEGF, has injection of steroids leading to mild reduction of IV phosphorus.
non-steroidal anti-inflammatory prevent conversion of arachidonic acid into prostaglandin, thromboxane, and procyclin, and also inhibit platelet function and blood formation. Non-steroidal anti-inflammatory drugs, as we know, can be used to avoid the known side effects of ocular steroid. The antifibrotic agents prevent scar formation by alteration of fibroblast proliferation and activity. The most commonly used agents, as we know, the vitamin C and 5-fluorouracil. These medications are used in conjunction with other pre-operative, post-operative medications to increase the success rate in glaucoma operation. Vitamin C acts against all cells regardless of its cycle, and it has direct toxic effect on the overlying conjunctiva, cilia epithelium, and inhibits angiogenetic activity of blood vessels. It is very potent, 100 times higher than 5-fluorouracil. Application of mitomycin leads to disappearance of all fibroblast cells, while in 5-fluorouracil still we have some fibroblasts. 5-fluorouracil inhibits DNases. It acts selectively on the S phase of the cell cycle, affecting the activity of replicating cells. The antimetabolites indicated high risk conditions, which may be due to patient factor or ocular factors. Patient factor: young, black races, previous chronic medical therapy, previously failed tracheotomy, or due to any ocular factors, secondary glaucomas, congenital, pediatric, traumatic, aphakic, and pseudophakic glaucomas. In spite of increasing the success rate in glaucoma surgery with the use of these antimetabolites, most ophthalmologists don't use it in every glaucoma case for overall caused by these medications by corneal epithelial defect, especially with 5-fluorouracil use. Cystic cell wall deplete, especially with mitomycin C leading to chronic hypotony, related endophthalmitis, and hypotony. The new method, anti-VEGF, the early phase of wound healing lead to angiogenesis and the new blood vessels formation and subsequent release of inflammatory mediators, cytokines that lead to scar formation and bleed failure. Last one, those factors, VEGF, is present in high concentration after glaucoma surgery, the high after 7 days post-op. The use of anti-VEGF agents has expanded greatly over recent years and include Avastin, used intravitreal or subconjunctival. Also, use of Avastin leading to a reduction of IOP, which is compared with mitomycin C. And also, since the intraoperative sense has the same results of mitomycin C, but the blip height and the perspective was significantly reduced in the lucentis as we see. This blip with lucentis, this vascularized as we see. CAS 152 is a novel monoclonal antibodies which inhibit anti-tissue responses. It is a potent fibroblast proliferation, collagen deposition, and angiogenesis. Decorin, which is naturally locating tissue response, potentially safer because of the possibility of low immunogenicity. So I mean, inhibit virus factors also. Transferase, it is anti-allergic agents inhibit fibroblast-derived allergen synthesis. Signal pathway inhibitors block signal transduction pathway, of which tissue growth factor B exerts its inflammatory and inhibitory effect in wound healing. But it is still under experimental trials. Amyloid B is a natural occurring protein. It is potent regulator of monocyte macrophage and inhibit draw fibrotic cytokines and phosphorylase. And this 1 phosphate overproduction of S1B has been implicated in the medicinal angiogenesis. Serotine protein originally isolated from the saliva of the leech. It interferes with platelets integrin and prevent platelets aggregation in the adhesions, and also interfere with the binding of regulatory cells. cRNA gene silent has been used to modulate the action of fibroblasts and reduce the scar, and also can gene cells. Lastly, radiation, single application of radiation, Strontium 90 applicator as the application of surgery have significant anti-drug effect. In conclusion, in high risk for treatment failure, use in high risk for treatment failure, use antibiotics. Histologic analysis shows that multiple treatment techniques have more favorable characteristics when compared with vancomycin C, including less epithelial thinning, collagen thinning, and Hopkins cell loss. Numerous studies are needed to find the ideal combination drug regimen with respect to the human eye response. Surgeon ability to fully modulate the healing process would ultimately allow them to improve the success rate and determine the long-term final IOP in patients undergoing glaucoma surgery. Thank you.
Thank you very much for Dr. Ahmed. Next presentation will be with Dr. Ahmed Mustafa Eid, trabeculectomy.
اولا بشكر الجمعيه على الدعوه الكريمه مع اعضاء المجلس وعلى رئيس الدكتور عادل، واشكر الحضور الوقت متاخر كده على استاذي الاستاذ الدكتور عامر خليل. اتكلم بسرعه indication of combined cataract glaucoma coexisting visually significant with uncontrolled when lens extraction help people material, avoid overfiltration material, avoid overfiltration and hypotony, secure watertight closure of scleral bag, prevent wound leak and overfiltration. Advantage of one side versus two قلنا عليها بسرعه اللي هي short surgical time وsingle lesion less induced astigmatism. الصوره تبين لي الانتيريور سيجمنت بالنسبه للريزلت غالبا كومبارابل افكتنس وسيفتي بروفايل. احنا برضو maintaining similar safety and efficacy to site approach. زي ما قلت true one side